Hello again. We are going to talk here about flutters and fibrillations. So this falls under our category of arrhythmias, and the most important one we're going to talk about here is atrial fibrillation. So we can classify the flutters and fibrillations into atrial and ventricular. Like I said, the most important one here is atrial fibrillation, and I say important as far as what you're going to see most commonly in clinical practice. As far as importance for the USMLE, I would say they're all equally important, but AFib is going to be something you'll see just day to day, especially if you're working on the wards. So we'll talk about atrial fibrillation. We'll also talk about atrial flutter. We'll also talk about ventricular fibrillation. This one's really important for another reason, and that is because this is a very, very big emergency. People who have ventricular fibrillation very commonly die. And so ventricular fibrillation is something that is always an emergency, and we'll also talk about this more in the Code Blue section. Ventricular flutter does exist, but it's clinically inconsequential as far as we're concerned for testing purposes. Okay, so atrial fibrillation. So what this is it's uncoordinated electrical activity of the atria. Now you might think, okay, that sounds similar to something I have heard before, namely supraventricular tachycardia. But what atrial fibrillation is it's basically where the atria are not having any kind of normal conduction pathway at all. In supraventricular tachycardia, you have normal electrical activity in that the conduction system can function, but you're getting impulses from different places or from an abnormal place that's not the SA node. With atrial fibrillation, usually what has happened in these patients is that their atria have enlarged. And because their atria has enlarged, their entire conduction system of their atria between their SA node and their AV node has become completely dysfunctional. And so they don't get normal electrical activity through their atria, even though they're getting conduction from their SA node trying to get to their AV node. It's the actual conduction system that's disordered. It's become stretched out. It's kind of like how you would look if you were a young woman and you got a cute tattoo on your belly, and then 20 years later you put on 300 pounds. It wouldn't look anything like what you got, so it would be essentially disordered. That's probably a pretty terrible analogy, but essentially what has happened is that the electrical system between the SA node and the AV node, the atria, has become disordered. And so because of that, you don't have very good atrial contraction. You have some, but the atria are just really not getting that strong, nice contraction. And remember, that strong, nice contraction that we get is what causes our P wave, that normal conduction from the SA node to the AV node. So like I said, usually atrial fibrillation is acquired, and it's usually due to anything that expands the heart. So congestive heart failure, coronary artery disease, which is the #1 cause of systolic congestive heart failure, or valvular disease, which can also cause atrial enlargement. One thing that comes to mind would be mitral valve stenosis. So on EKG, what you're going to note in these patients, and usually these patients are going to have other problems that are going to indicate that they need an EKG. So they're going to have COPD, or they're going to have congestive heart failure and pulmonary edema, or they're going to have a heart attack, or they're going to have something else that indicates that they need an EKG. Patients don't just come in and say, hey, I think I might have atrial fibrillation. Can you run an EKG? It doesn't happen. But what you might notice, if these patients don't have any other symptoms, is that when you take their pulse, and usually the nurse will do this, but you will do it on USMLE CS, or if you're short-staffed, you go and take these patients' pulse, and you'll note that, oh, that pulse is not regular, in that it's not clicking like a clock. It's irregular. You hear a beat, 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 and it's not the normal rhythmic conduction that you would expect. So it's irregularly irregular. It's just heartbeats happening at random times. That's a possible sign of atrial fibrillation. But like I said, usually these patients are going to have another reason that they're getting an EKG, and then you'll see the atrial fibrillation on EKG. The labs for any patient, once you have diagnosed them with atrial fibrillation, and again, you probably will have gotten these labs because of other things they have, but all patients with atrial fibrillation should have a chest x-ray. They should have an echocardiogram, because one of the possible causes of atrial fibrillation is valvular disease. And they should have thyroid function tests, because hyperthyroidism is a rare but possible cause of atrial fibrillation. So chest x-ray, echo, and TFTs in any patient who has been newly diagnosed with atrial fibrillation. Now, two of the things that are bad that can happen with AFib. The AFib itself really isn't a big deal, because that blood, barring any kind of really severe valvular disease, is going to get to the ventricles one way or another. The really bad things that can happen with atrial fibrillation, first of which is mural embolism. So what that is because the atria are not squirting out the blood like they should, they're not pushing the blood out and ejecting with the same force, the blood kind of sits around there and it has time to linger. And when that happens, you can get clots. And so where would the clots go? Well, if you're in the left atria, you would go from the left atria, and the clot would travel to the left ventricle, and then it would travel out the aorta, and the number one place it would go where a clot would be noticed pretty quickly would be up the carotid artery and towards the brain. So this can be a risk factor for stroke, and so indeed, patients with atrial fibrillation are at risk for stroke, and we do treat them prophylactically, and we'll talk about that in a bit. Atrial fibrillation can also result in a temporary a paroxysmal rapid ventricular response, and so this is technically an SVT. So what happens when you have a rapid ventricular response is that you get fibrillation, you get these erratic electrical activity due to your disordered conduction system, but now you're stimulating the AV node. And because you're stimulating the AV node now, you're getting rapid ventricular response, because the AV node is what is the gatekeeper for ventricular conduction. So you can have atrial fibrillation with a rapid ventricular response, and that can be bad, because if you just have ventricular contraction without actually filling the ventricles, you're not pumping blood out, and so your blood pressure will drop, and so that can cause hemodynamic instability. And so that would be a time where you would definitely need to cardiovert the patient. There's nothing else you can do for that patient. Okay, so here's kind of what, sort of a diagram. So I would like to, if I drew this, I would make this heart nice and big, so you could highlight that most of these patients with atrial fibrillation have congestive heart disease or have some kind of intrinsic problem with their heart, other than just a normal-looking heart. But you have an abnormal electrical pathway, usually due to what's called electromechanical dissociation, so you're not getting atrial depolarization as it should happen. And so you get these sort of erratic kind of electrical activity before your QRS. Your P wave is sort of, you're not getting that nice peaked P wave because you don't have a nice strong atrial contraction. You're getting this kind of fibrillating electrical activity in your atria. And so normal here, abnormal here. Okay, here's another one. So this is very distinct. It's just tiny fibrillating waves in between the heartbeats. And your T wave is actually kind of enveloped into this fibrillation too. So that's another thing. You might not see your T waves. But what's characteristic though of the atrial fibrillation is that irregular heartbeat. So notice here in the normal patient, you've got about 5 blocks between each QRS complex, so 60 beats per minute. Here you've got a various number of blocks, different numbers depending. So you have an irregular rhythm. It says erratic here. I like that word. Okay, so here's another one. And another one. And another one. Okay, so in emergency settings, when you have atrial fibrillation with hemodynamic instability, so this would be the patient with atrial fibrillation and they have that rapid ventricular response and they have hemodynamic instability. What you're going to need to do for these patients, so they're going to have hypotension, they might have an acute development of congestive heart failure, they're going to have weak pulses because they're not getting blood out of their ventricles because their atria are completely fibrillated and their ventricles are not pumping blood out. So they're going to have hypotension, weak pulses, blood's going to be backed up into their lungs, so they're going to have pulmonary edema symptoms, shortness of breath, dyspnea, they're going to feel like they're drowning. What you're going to do with these patients, as soon as you get an EKG and you see atrial fibrillation, it's not going to show anything else other than atrial fibrillation and possibly a very rapid heart rate. You're going to immediately cardiovert these patients. So you're not going to mess around with any drugs. This is one of the rare cases in arrhythmias where we just go straight to cardioversion because these patients are at risk of sudden death. So immediate progressive cardioversion starting at 100 joules. You don't really need to know the intensity for that until you get these patients into sinus rhythm. Now, if the patients have atrial fibrillation and rapid ventricular response and they're stable, usually they'll feel palpitations because they've got tachycardia. But if they're stable, you can just go ahead and use a calcium channel blocker. And what the calcium channel blocker does is it blocks the AV node. So it increases the threshold to activate the AV node. And so that's going to stabilize the conduction down the ventricles. So calcium channel blocker is fine for AFib with rapid ventricular response if the patient is stable. But if the patient is hypotensive and they're developing heart failure and their pulses are weak, you're going to consider that unstable and you're going to go ahead and cardiovert them. Don't even bother with the meds because they take a while to work. Now, if a patient has a stroke or a transient ischemic attack associated with AFib, I just put that here just so you know that that's an emergency possibility of AFib. Not going to talk about how we treat transient ischemic attacks or strokes. That's a neurology topic. But just know that patients that have confusion and hemiparalysis and aphasia, good to get an EKG because if you see, oh, gee, this patient has AFib, definite possibility that it's a stroke. So, but that's the stroke protocol is something that we'll talk about in a neurology section. Okay, so how do we treat these patients on an outpatient basis? Patients with AFib. We manage these patients twofold. First, we want to make sure that they have proper rhythm. We don't want patients having their ventricles pumping stuff out that's nothing. We want their ventricles pumping blood out, not air. So we want to make sure that we have a proper rhythm. So the way we ensure proper rhythm is with a calcium channel blocker. And that's just what we use in the emergency management of a patient with AFib with rapid ventricular response. We just give them a calcium channel blocker. It would probably be, in this case, an IV calcium channel blocker, like IV deltiazem or IV verapamil. But in patients on an outpatient basis, we give them calcium channel blockers. Why? Because, again, the calcium channel blocker, what it serves to do essentially, this isn't the exact mechanism, but what it serves to do is it raises the threshold of where the AV node needs to be stimulated to conduct down through the ventricles. And so what happens then is that you get a more regular heart rate. It doesn't just take any little kind of fibrillation to conduct down the ventricles. And so the calcium channel blockers are good because they will regulate the rate. So you'll have a proper rhythm. You'll have more association between your atrial conduction with your ventricular conduction. And that's good because it helps you get blood out your ventricles because you have to have blood conducted into your ventricles in order to get blood out of your ventricles. So we use calcium channel blockers. Those tend to be the best. Beta blockers and digoxin are also effective, but calcium channel blockers are the best drug for atrial fibrillation. We also use anticoagulants. Why? Because while we may be giving them a proper rhythm, we're not completely getting rid of their AFib. So you're going to have a little stasis in your atria, and you're going to have possibility of coagulation, and especially in patients who are already risk factor for clots and risk factors with coronary artery disease and stroke. We want to make sure that these patients are well anticoagulated because they have such a risk factor for stroke with their AFib. So we give them warfarin as long as the patient doesn't have a contraindication. Clopidogrel would be what you would substitute, but know that calcium channel blockers and Coumadin or warfarin is what you're going to have a patient managed on outpatient with AFib. These patients with AFib definitely need to be frequently monitored, so I would say that these patients should be coming in about every 3 months to have their INR checked, if not every month to start with. We want their INR to be between 2 and 3. And then these patients should have periodic EKGs or Holter assessments. What a Holter is it's just an EKG that you get to wear at home, and we can read over a 24-hour period. So we can see how you're doing over a long period of time as opposed to just a period of like 10 minutes. Cardioversion can be used for patients with atrial fibrillation, but on the USMLE, as far as it's concerned, you're just going to be managing with medical therapy. So this is the CHADS-2 score for stroke, and I included this just because I want to emphasize that patients with atrial fibrillation are at significant risk of stroke, particularly if they have other risk factors. So we definitely need to make sure that we're including anticoagulation into their outpatient treatment regimen. So what CHADS-2 is it's CHADS, and the S stands for 2, because each letter gets a point, and the S gets 2 points. So if the patient has congestive heart failure, that's 1 point. This is just all in addition to their AFib. So if the patient has AFib, you go down the line and add up the points for CHADS-2. Congestive heart failure, that's 1 point. If the patient has hypertension, regardless of whether you're treating it, if the patient has hypertension, that's another point. If they're older than 75, that's another point. If the patient has diabetes mellitus, type 1 or type 2, that's another point. If the patient has a personal history of stroke, not a family history, personal history of stroke or TIA, that's 2 points. So you add all these up, and this tells you what their annual stroke risk is, approximately. So if you have a 78-year-old patient who's got diabetes and is being treated with ACE inhibitors and beta blockers for their hypertension, that would be 3 points. And so this patient has a 6% chance each year of having a stroke. If they developed congestive heart failure, then it would go up to 8.5%. So that's what CHADS-2 is. But regardless, you should have all patients with AFib treated on an anticoagulant. Okay, so atrial flutter is different from atrial fibrillation in that what atrial flutter is caused by is an atrial reentrant circuit. So this is not Wolff-Parkinson-White syndrome. This is not where the conduction goes down from the SA node to the AV node, through the ventricles, and then back up to the atria, and then back down through the AV node and back and forth and back and forth. This atrial flutter is a conduction circuit within the atria itself, and it's self-stimulating and then going down and then conducting through the atria. So it has nothing to do with the SA node, has nothing to do with the AV node. This is just a self-stimulating circuit in the atria. If you know what VTAC is, which is a self-stimulating circuit within the ventricles, which is a big problem because you get rapid ventricular depolarization, that's an emergency, of course. This is just the atrial equivalent to VTAC. You're getting rapid atrial depolarization because of a reentrant circuit in the atria. Now, unlike VTAC, atrial flutter is not an emergency. And the reason is because your ventricles are still able to get blood, and the ventricles are doing fine, and they can still pump blood out. So this is not as big a deal as its equivalent in the ventricles. So patients with atrial flutter usually will present again with palpitations. They do usually have tachycardia, and they can also present with shortness of breath, lightheadedness, syncope. So sort of your non-specific arrhythmic symptoms. But what you see on EKG is you see atrial tachycardia. And the way that shows up is these sawtooth waves, which really all they are they're just a bunch of P waves in a big line. Because you've got this reentrant circuit in your atria that's saying atria depolarize, atria depolarize, atria depolarize, over and over and over and over again, regardless of what the SA node is saying. So that is atrial flutter. And this can also cause a rapid ventricular response, just like atrial fibrillation can, if it gets down to the AV node. It doesn't have to, but if it gets down to the AV node, then you can get a rapid ventricular response, and then you will get tachycardia, significant tachycardia, and that can cause the hemodynamic instability because you're not getting blood out of your ventricles and up to the systemic circulation. So here is atrial flutter. You do indeed have a tachycardia here. Actually, no, this is not tachycardic. I take that back. This is only about 75, 80 beats per minute. There's only 4 blocks between them. So this patient is not hemodynamically unstable. There's no rapid ventricular response here. They just have a lot of P waves. You're getting P wave, P wave, P wave, P wave, and then your QRS. P wave, P wave, P wave, QRS. So, and it's different from AV nodal block in that you don't have bradycardia here. You have a normal heart rate. So this is atrial flutter, and this is called a sawtooth rhythm. It's just these multiple P waves lined up. Here's another one. Again, this is not a tachycardia on this one either. It's a little closer, but it's not quite. And here's another one. So this very distinctive sawtooth rhythm. Okay, so what I want you to differentiate atrial flutter from this is just on the EKG. These patients are totally different patients in how they present, but when you look at an EKG, they can look kind of similar. Remember, multifocal atrial tachycardia is where you have an SVT where you have a abnormal or different looking P waves. With atrial flutter, you just have multiple P waves, but they all kind of look the same. Okay, so the way we treat atrial flutter, we're going to treat it in pretty much the same way we treat atrial fibrillation. And so we are going to want to have rate control, and we're going to want to prevent thromboembolic complications. I don't really know physically why atrial flutter would lend itself to mural embolism as much as atrial fibrillation, but the studies have been done, and atrial flutter is associated with an increased risk for embolism, so we do treat with anticoagulation. So we're going to give calcium channel blockers, again, to raise that threshold for ventricular conduction, and we use calcium channel blockers, and then warfarin for anticoagulation. So we pretty much treat this just like AFib. But it is a distinctive EKG. This is not an AFib EKG, clearly. And again, cardioversion can be used, but generally patients with atrial flutter are not unstable. Okay, ventricular fibrillation we're not going to give a lot of talk to here because I'm going to devote an entire set of slides to patients who are code blue. So ventricular fibrillation is where we have it's the equivalent of atrial fibrillation in the ventricles. So we have no coordinated electrical activity in the ventricles. And you can imagine why this would be a problem. Ventricles aren't pumping. Ventricles aren't pumping, you're not getting blood out of your heart, blood is backing up, blood's not going out to the system, blood pressure drops, patient dies. So this is a medical emergency. These patients are always going to be hemodynamically unstable, and generally these patients will be pulseless. So the EKG will show an erratic rhythm. It's pretty clear when you look at the EKG. You don't really see much of anything other than, fibrillation. What you would normally see on AFib, you just see the whole time. And there are really no discernible features. You don't really see anything that looks like P waves. You don't really see anything that looks like QRS waves. Nothing that looks like T waves. It's really just kind of an erratic rhythm. Treatment here is obviously emergent. You want to have IV access. You're going to begin administering CPR immediately. You're not going to waste any time. Yes, you're going to get your crash cart. Yes, you're going to hit the code blue button, but somebody should be administering the CPR right away. You're going to prepare your defibrillator because you're probably going to need it. Actually, you will need it because the first thing you're going to do is shock this patient. You'll give one shock at an appropriate power for the device, which is usually on a biphasic device, usually between 120 and 200 joules. At that point, then you'll check your rhythm and you'll continue 5 rounds of CPR. At that point, then you can start using medical management, and then you're going to basically alternate medical management and defibrillation and CPR, and we'll talk about that in how we manage code blue patients in a different section, but that's just the basics here. So that's ventricular fibrillation, and you can see here, this is not VTAC, this is ventricular fibrillation. VTAC would be a higher amplitude, and you can see here, this, you wouldn't see little spots like this in VTAC. This is even more obviously VTAC. Now this patient, I picked this one out because you can see, sometimes you see little QRS complexes in VFib. Why do you see QRS complexes? Some patients have pacemakers, and those pacemakers are still trying to work. So if you look between the pacemakers, you still do see what looks like VFib, and this patient is indeed in VFib. Here's another VFib. Obviously not VTAC. VTAC would be wonk, 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 wonk. So this is VFib here.